right, so thank you so much. Thank you for this opportunity again. I'm so excited to share this work. So this is a rare condition that I wanted to report, and I'm actually writing down as a case report now. It's a case about pulmonary tumor thrombotic microangiopathy. This is a young lady who presented to the ED with shortness of breath and respiratory distress, and she only has a medical condition of asthma, and so she had repeat admissions in the past for similar clinical presentations, and she was presumed to have asthma exacerbations. And that's when she used to receive treatments of breathing treatments and inhalers and steroids, but she never improved. And so she presented this time with worsening respiratory distress. And so she got admitted. We did a CTA of her chest, and it ruled out any PEs. But it did show some ground glass opacities and nodularities that was consistent or at least suspicious for bronchopneumonia. We started her on antibiotics. She failed to improve. We broadened the antibiotics. We put ID on board. We did extensive ID workup. She wasn't an immunocompromised person. All her cultures came back negative. And despite that, the patient continued to deteriorate and her respiratory status worsened. She became more hypoxemic. And so I ordered a BNP on this patient, and who expected that a young patient who's 26 years old to be having heart failure. But then surprisingly, her BNP was elevated at 4,000. And this prompted us to order an echo for her. And then as you can see in the slide, the echocardiogram showed that the RV was severely, massively dilated. And as you can see in the first figure, there's this D sign where the LV is much smaller than the RV because there was right ventricular pressure and volume overload, and it was pushing against the LV. And that's why the right ventricle was dilated. So apparently the patient had this, and then the echocardiogram also showed that she had severe pulmonary hypertension. Her RVSP was 115. So this was primarily the cause of her respiratory distress and worsening status. And so the patient was transferred to a cardiac ICU unit. But then as we attempted to place a Swan-Ganz catheter in her so we can monitor her hemodynamics. But then her symptoms just deteriorated, and then she expired. On post-mortem examination, the lung histopathology showed that there was extensive tumor cells occluding the lymphovascular structures in the lungs, and that was causing her acute/subacute pulmonary hypertension and her right-sided heart failure. So this was a very unexpected case because this patient clearly had undiagnosed gastric cancer that has metastasized to the lungs and has occluded her vessels and caused the severe pulmonary hypertension and right-sided heart failure and eventually death. So this condition is called pulmonary tumor thrombotic microangiopathy. It's a very rare condition. It's even rarely reported in the literature, and it has a very dismal prognosis. Around 4 out of every 5 individuals are diagnosed post-mortem, and it has a rapidly progressive course. So and very poor prognosis. So this case really aims to familiarize clinicians with this rare diagnostic entity so that in the future for patients who present with worsening dyspnea, severe pulmonary hypertension, this could be placed on the differentials and considered as part of the differential diagnosis. And also another learning point from this case would be, patients who present with refractory dyspnea or non-responsive, symptoms of shortness of breath, or right-sided heart failure or severe pulmonary hypertension, not responding to conservative management. this could be just, a good indication to do a bedside focus on these patients, because especially this patient, she had multiple ED presentations for the same worsening symptoms, and she would every time be discharged on a course of steroids and inhalers for asthma exacerbation, because who would have expected that, a young adult with no comorbidities would have cardiac, she has no cardiac history, and she would present with with these cardiac manifestations and findings. So a bedside echo, even us as residents, and we're doing a QI project on that, we're beginners with focuses, just doing a quick bedside focus would really point out to very helpful information, like checking out the RV chamber and seeing if there's any signs of RV overload, whether it's from PE or, as is, in this case, it was from metastatic cancer cells occluding the pulmonary vasculature and causing severe pulmonary hypertension, causing RV overload. So doing a bedside focus would really be helpful. Just to take a quick overview of the heart condition, of the EF, of the contractility, of the chamber sizes, of the pressure and volume status. So and at this point, it's just about raising awareness and education on this rare condition. So further research can take place to try to find ways to better diagnose it in its early stages, and treat the underlying condition, detect the cancer at its early stages, and start treating that, so it can help with prognostication. And that was the case. So these two echoes, they show how this patient had severe pulmonary hypertension, and her RV was very dilated. So the first one is a parasternal short axis view, and it shows that the RV is larger than the LV, and the D sign is clearly evident, as the D sign is where you see like the LV is in the form of a D, because it's being compressed by the expanding RV. And the other view, it's a 4-chamber view, and it also shows that the RV is much larger than the LV, and clearly there is volume and pressure overload that should raise suspicion for pulmonary hypertension and the underlying causes of it, and so it can be better treated. So that is primarily my case report. If you have any questions, please let me know.
Yeah, great job. Thank you, Dr. Ali. That was fantastic.
Thank
The
you.
one question I do have, in retrospect, was there anything else about the presentation of this patient that would have made you kind of consider PTTM as a diagnosis?
So that's the thing with PTTM. It comes insidiously. It comes like even as written in the title, it's occult gastric cancer. So PTTM is mainly caused by metastatic cancers, and the most common is gastric adenocarcinoma, where these tumor cells would embolize, and they would occlude the vasculature and cause this acute pulmonary hypertension and the acute symptoms as this patient presented with. So I wouldn't suspect it from the first presentation, but when the patient continues to experience worsening symptoms of hypoxemia, shortness of breath, and respiratory distress, I mean, if we just do a quick bedside focus, we would be able to find these pertinent findings of severe pulmonary hypertension, and that would lead us to start ruling out differentials, including PE, including other causes of we have 5 groups of pulmonary hypertension, and start ruling out what could be causing that in this patient. And that's when we start putting it on our differentials. That's when we start thinking about it. Otherwise, it's really hard to. It doesn't come clearly as a PTTM. It needs to be considered as part of the differentials in order to start working it out.